So good afternoon, namaste, and welcome yet again for one more episode of Empower Hour by Association of Nurse Executives India. I am Thankam Gomez. I am the founder president, and we are very honored that we are starting today 900 participants. Congratulations and thank you everyone for being here. Just give me a moment before I hand it over to our, verse. So friends, just give me 1 second before I say a few things. So this session is around learning ignited from errors. Association of Nurse Executives India is committed to preventable zero harm. And every month we are hosting one event which is being discussed by one of the chapters. We have 14 chapters of Association of Nurse Executives India. So this May month, we could not host it because we had our annual conference, which was a huge success. Thank you everyone for supporting and making it a extremely successful and very learning experience. So ANECON was held at AIG Hospital, Hyderabad, and we had packed auditorium and we had great collaboration with many other, departmental heads who were coming as speakers and joining as, participants. Even we had industry partners. So thank you, everyone. That is our website, www.anei.in. And if you go there, you will find all information about us. We also had a pre-conference workshop, which was around simulation, which again was a huge success. Thank you, everyone. We had 30 participants attending that. Now, coming to this month's, team, as promised during ANECON, we have agreed that, our association will take endeavors, take actions to collaborate with other team members of the healthcare system. So I'm very happy that today, as the Northeast team is going to discuss the safety event, we do have our first non-nurse, faculty, Dr. Karabi Patawari, consultant anesthesiologist from Apollo Hospital, Guwahati. We are very happy and thankful to her to be participating in this discussion. And thank you to the Northeast team, and you can see them on the screen. But I am not going to take time to introduce each one of them. I'm going to leave the job to Dr. Ranjurani Das, President Northeast Chapter, and she's also the Vice Principal of Asian Institute of Nursing Education, Guwahati. Before I invite Dr. Ranjurani, it is my privilege to also invite Dr. Unmana Borgohain, who was the last president of the Northeast chapter, and now she is the vice president of Association of Nurse Executives India. Dr. Unmana, can I ask you to please put on the video and say a few words before we hand it over to Dr. Ranjurani.
Good morning to one and all. On the very onset, I'm very happy and privileged to be in this association from the very inception, and the root person, Ma'am Thankam Gomez. I'm so happy to see today, to see from the beginning, and the way she is upholding us, definitely much better future we have in coming days. And particularly, I always admire in the sense the topic she brought up, and she not only push us, not only pull us. Sorry, the video is she is the main intellectual brain and creativity and innovation, and bringing up lot of innovative, important and vital topics. And particularly that today's topic is very important. If anything goes wrong, that we cannot save the life. And I'm very happy that we are also having doctor who, wherever we walk, whenever we walk in the healthcare sector, we cannot walk alone, and we have to walk in team. And I'm very thankful to Dr. Korobi for joining us, and that much from my side. And I request all the members, to to wait for the next session, what is going to come, Empower Hour. I'm very sure it will definitely empower you skillfully, intellectually, and I request each one of you, if you are not yet member, don't miss the situation, join it fast, and you can learn many more. That's all from my side, ma'am. Thank you so much. Thank you so much.
Thank you. Thank you, Dr. Unmana. Thank you for your kind words. We are all in it together, not together. It's a team effort. Thank you very much. So without any delay, let me invite Dr. Ranju Rani Das, President, Northeast Chapter, to come and then introduce your team members. Thank you very much and all the very best.
Thank you, ma'am. A very warm good morning to one and all present in this platform. Before starting today's session in Empower Hour, I, on behalf of ANEI chapter, I express my sincere gratitude to Madam Thangam, the former president and founder member of ANEI, for her constant guidance and support, and also for initiating such an wonderful platform for learning and the quality improvement. I also would like to thank Dr. Unmana Borgohai Soikia. Madam is sick, but even then she has joined us. Thank you, ma'am. And also I'd like to thank all the national ANEI officials for giving us this opportunity to be the part of Empower Hour. I welcome all the participants to today's discussion on accidental delining epidural catheter. The discussion will be held through a role play, and the incident is already, madam, you have not narrated the story. So I'll narrate the story. I'll narrate the story. And before that, I'll introduce the today's team who is representing the Northeast chapter. Today we have Mrs. Pinaki Bayan. She is the ANEI member, Nursing Superintendent, Apollo Hospital, Guwahati. She will be playing the role of Nursing Superintendent. We have Dr. Momi Neu.
On the video, please, Dr. Pinaki. As Dr. Renjo calls out name, please come on the video.
Yes, Mrs. Pinaki Bayan.
Yes.
Welcome. I welcome you. Okay, next we have Dr. Momi Neuk. She is also ANEI member. She is the Nursing Superintendent, Assam Medical College Hospital, Guwahati. She will be doing the role of inserts. Next, we have Ms. Rosita Devi. She is also ANEI member. She is the nurse educator in Apollo Excel Care Hospital, Guwahati. Rosita.
Yes, ma'am. Good morning. Good afternoon, everyone.
Next, we have Ibha Mary. She is the staff nurse in GNRC Hospital. And also, I forgot to tell the role of Rosita, role of quality nurse, and Eva will be playing the role of staff nurse. We are very much fortunate to have Dr. Korobi Patwari, consultant anesthesiologist, Apollo Hospital, Guwahati, who is with us. I welcome ma'am, and she will be enlightening us about the epidural catheter. So I welcome the team, Northeast team, and now I'll remain silent. Over to you, team. All the team member, please come on.
Just give me 1 minute. May I request all of you to stay muted, please? Those who are speaking only have to unmute. Dr. Pinaki and Dr. Kharbi, please stay on the video. Please do not put off the video. Thank you, because I have pinned you up. So please stay on the video. And where is Eva? Eva, please come on the video. Eva?
Yes, ma'am. Ma'am, I'm not able to start my video, ma'am.
Please try again. What happened? Because you should be on the video.
No, ma'am, I'm not able to open my video.
Can you log out and come in again?
Sure, ma'am, I'll do that.
Just give 1 second, and I am going to just share the today's scenario. Okay. Yeah. So that is the case for today for the team to discuss. A 34 years old male admitted to the hospital with the diagnosis of right multi-ligament injury. The patient had undergone surgery on 29/12/2021. The error that happened during hospitalization was the accidental removal of epidural catheter on 30th, that is postoperative, day 1. So that is the event. And please note that this event has nothing to do with any of the hospitals who are, involved here in discussion. So this is all anonymous. We have collected the stories from various, sources. So Eva is also here. Let me just pin her up. And so now we have everybody on the screen, and you will always be on the screen. So please stay on the video so that everybody can see each other. And my humble request to everyone else in the group is that please stay muted. Please do not disturb the discussions. And while you are not discussing, to the people on the panel, please keep yourself muted, because there are some background sounds that keep coming. Only when you're talking, you can leave it, Eva, there is some background sound coming. Can you mute yourself? Thank you. So now we hand it over to, again, back to the Northeast team and to Pinaki. Is that correct?
Yes.
Yeah.
Yes, ma'am.
I say off the video, off the audio. Thank you very much. Please start, Pinaki.
Hi, good morning, everyone. Today we'll have a role play on how to deal with accidental delining of epidural catheter. So I request my team member Eva to come on for starting with role play.
Ma'am,
Yes, Eva.
ma'am, it's very urgent. I want to speak to you about bed number 10, ma'am. Please come with me, ma'am. It's very important.
Bed number 10. Bed number 10.
Yes,
Okay.
ma'am. Bed number 10.
John, Mr. John. You
Yes,
mean Mr.
ma'am.
John, right? Yeah.
Yes, ma'am, Mr. John.
What happened? I talked to him in the morning. He was doing pretty good. Today is his first post-operative day, right? What happened?
Yes,
Eva,
ma'am.
tell me.
Ma'am, actually, while changing his position, accidentally his epidural catheter it got disconnected. It came out, ma'am.
Oh, that's not a good news for me, of course, Eva. And what did you tell the patient immediately?
Ma'am, nothing. I didn't say anything. I just came running to you because I was very scared as this happened to me for the very first time.
Okay. Okay, let's go. Let's go to the patient immediately.
Yes, ma'am.
You drag the dressing trolley along with you. Come.
Yes, ma'am.
In the meantime, tell me what exactly you were doing.
Ma'am, actually, we were trying to change his position along with the help of nursing aid. So unknowingly, she pulled out the catheter. So it came out, ma'am.
Where was Mary, your colleague? Where was she?
Ma'am, she was there, but she was very busy. So I didn't want to interrupt her. So I thought I'll be able to do this with the nursing aid. So like as I have been doing this for all these years, so I thought I'll be able to do it. But ma'am, it was my mistake that I should have called her for help, ma'am.
Exactly. You could have waited for 5-10 minutes. That would not have made much of a difference to Mr. John, I guess, right?
That's right.
Yeah, or you could have just called me. I could have come to help you because the nursing aide would definitely not know about the importance of the epidural catheter. Right, Eva? Okay, relax now. Let's go.
Okay, ma'am.
Hello, Mr. John. You have been doing pretty good. Okay, let's see, Eva, show me the catheter first. Show me the catheter.
Ma'am, this is the catheter.
Okay. So this catheter has come out in toto, so relax. No worries. Mr. John, so you have come to know that your catheter has come out just now, but as it has come out in toto, so you need not worry. There should not be any worries because you may not need it any further also because it's already been more than 24 hours, but still we'll see to it. Eva, you inform the treating doctor immediately. Okay.
Okay, I will do that. I'll do that, ma'am, now.
And you wash your hands, get ready, and check the site
please. Okay,
Yes, ma'am.
get ready, wash your hands, put on the gloves, and then you check the site. Okay. Okay, Mr. John, you have been so strong all throughout. Wonderful, really. And thank you so much for being so strong and being so cooperative. You will be monitored. Let's see. And that's your brother, right? Standing near you since yesterday. So wonderful that you have such a supportive family with you. That's really wonderful. Thank you. Thank you for being so supportive. Eva, are you done?
I am done, ma'am.
Have you checked the vitals?
Yes, ma'am. I have checked the vitals, ma'am.
All good?
Yes, ma'am. All vitals are stable, ma'am.
Okay. So is there any swelling in the site? Any leakage?
No, ma'am. Stockage is not there, ma'am. Swelling also it's not present, ma'am. I have checked it.
Okay, okay. No redness as such?
Redness is not there, ma'am.
Okay, okay. That's good. Okay. I can also see. So
They can see, no?
Eva?
Yes, ma'am.
Eva? Okay. You continue with your remaining work. I will also continue with my remaining work, and then we have to go and talk to our NS ma'am. Okay, at the end of our shift, I'll give her a call. In the meantime, we have to keep on monitoring Mr. John. Okay, Mr. John, okay, you are doing good so far. Take care. We are there with you. And Eva, I'm there. Don't worry, relax. If there is anything, please call me. Okay?
Okay, ma'am. Thank you so much, ma'am.
Okay. Okay, let me call our NS ma'am.
Okay.
Hello, ma'am. Ma'am Pinaki, are you there?
Hi, mommy. Good morning.
Good morning, ma'am.
How
Good
are
morning.
you? How are
Doing
you
good,
today?
ma'am. Thank you. Thank you. Ma'am, I
Okay,
need to
okay.
talk to you about one incident in my ward just now.
Okay. What is that?
Ma'am, actually, one of my post-operative patient, the epidural catheter got dislodged accidentally. So we need to
Okay.
come and talk to you, ma'am. When can we come?
Mommy, is the person okay? How is he now? I need to understand what is the condition now?
Ma'am, everything is good so far. The catheter has come out in toto. So, and the treating doctor also has been informed. The patient is
Very
quite
good.
is stable, and I have talked to the patient and his family member also. So they are quite cooperative. So everything is okay now, ma'am.
Okay, fantastic. So since the catheter came out, now you have to do a periodic pain assessment, reassessment, and if there is any other analgesia required, please make sure that it is given. So please keep in touch with the anesthesiologist because that's very important. They are the one who take care of the pain, post-op pain particularly. And maybe since you are taking care of it, so no worry, take your time, finish your important work, and you can bring the staff nurse, Miss Eva, and I'm in the office, no issue. Come around 3 o'clock, we'll discuss in detail. Is it okay for you?
Yes, ma'am. Yes, ma'am. Sure. The patient is doing good. And as such, he did not complain any pain also in the morning when I talked to him. So far, so
Right.
good. So, ma'am, okay, we'll come to you at around 3 p.m. Okay?
Okay,
Okay,
fine.
okay.
Thank you.
Ma'am. Thank you.
Ma'am, I am done with my shift. So can we go and speak to NS ma'am now, ma'am?
Sure, sure. So, Eva, I have been waiting for you only. Come, let's go.
Hi, mommy. Come inside. Mommy, Eva, please come
Yes.
inside.
Thank you, ma'am.
Okay, so, okay. Please sit down, relax.
Thank you, ma'am.
Okay, so would you like to have a cup of tea now?
No, ma'am, it's fine. Thank you so much.
It's okay,
Okay.
ma'am.
What
Thank you.
about
I
you?
just had my cup of tea. So thank you.
Okay, fantastic. So, mommy, you were saying about one incident over phone. So, what do you say? Eva, would you like to tell about the incident? What happened today?
No, ma'am, that exactly what ma'am Momi have explained you. The same thing happened, ma'am, to the patient whom I was assigned, Mr. John.
Right. So what happened with the zone? Because I really did not talk so much with mommy. She only assured me that everything is fine, but would like to hear from you. Little more detail. Eva, can you please
Yes, ma'am.
elaborate? Yeah.
Ma'am, actually, we were me along with the nursing aide. We were trying to change his position. So unknowingly, the nursing aide she pulled out the catheter as we were trying to put his bed sheet in place. So after that, we saw and immediately I informed our in charge, ma'am.
Okay.
Yes.
Okay, fine. So like following that, you and mommy have taken care of the patient?
Yes, ma'am. Immediately I've informed her, then I check his vitals. His vitals are stable, ma'am. Then I have
Okay.
checked for stoppage. Stoppage is not present. Along with the redness was not there. And I have assessed the patient, and the patient said he's not having any pain as of now, ma'am.
And you have done a dressing again, right?
Yes, ma'am. The
Because,
dressing we have done it, ma'am.
right, very nice. So you need to do periodic pain assessment, and accordingly, if he's complaining of pain, maybe according to doctor order, you have to give analgesic. So probably you have handed over all the information to your next staff, right, Eva?
Yes, ma'am. I have given the handover, ma'am.
Oh, fantastic. So, like, I'm able to understand that you are not taking the help of staff nurse. You have taken the help of nursing assistant. So, mommy, what happened actually? Why that, such important work and with patient with that kind of line, she has gone along with the aid. What is that actually, mommy? Why is happening all this?
Yes, ma'am. Yes, actually, since both Eva and Mary, both of them are actually senior nurses, and they have been working in my ward for last almost 5 years. So, I also was quite confident that they will manage the patients in the ward, and I got busy with my own work. I'm really sorry. I should have checked actually, but I took it for granted that both of them will be able to manage. But fortunately, there has been no complication, and then
Right.
she managed the patient, and I checked while she was changing the dressing and all. She was doing it with complete aseptic technique, and so I'm happy with whatever she have done after that. But from now onwards, of course, I need to check. I need to check
Yeah.
even if I have senior nurses in my ward. I need to check. Exactly.
Mommy, we keep talking about, competency assessment, privileging, because see, nursing aid, they are not privileged to deal with epidural line. All of us, we know, right? So it's
Yes.
okay. I mean, this is a learning lesson for all of us. There are some certain work they can do, but not the all work they will be able to help us. So we need to make sure that who is privileged to do what job, and based on their competency assessment, we need to assign. It's okay, no problem. So what I need to tell you, Mommy and Eva, I think we should call upon even our quality nurse, Miss Rosita, because I believe that she should be a part of our discussion. So let me immediately call Rosita, okay? Just hold on, just sit for 2 minutes.
Okay, ma'am.
Hi, Rosita. How are you? Where are you, Rosita?
Ma'am, good evening, ma'am. Ma'am, I'm in the ward. I'm good, ma'am.
Okay, fine. Rosita, if you don't mind, please come to my office because we need to discuss something, very important. Miss Mommy from surgery ward, along with her staff, Eva is with me. So if you can come, it will be really grateful.
Okay, ma'am. Sure, ma'am. I'll be there in 5 minutes, ma'am.
Right, please come.
Ma'am, may I come in?
Hi, Rosita, please come.
Ye-
Have a seat, please. Yeah, please
Thank
sit
you.
down. Okay. Rosita, actually, it so happened that, there is one incident in surgery ward today with bed number 10, Mr. John. Actually, morning I also visited. He was doing okay. Nothing is, there is no problem. But then suddenly I got to know there is an accidental delining of epidural line, which was inserted yesterday in the OT, and he has completed for 24 hours already. So Rosita, incident is already occurred, and I'm very thankful that Mommy and Ibha reported in timely manner. They also have informed to anesthesiologist immediately, and they have done, I think, the corrective part of it. But at the same time, it's so important that this is an incident we should not ignore. Rosita, being a quality nurse, I really feel that you should, take little more time and analyze as per the quality assessment tool, as you know about it. So I think we should do a proper root cause analysis here, as well as since corrective actions are more or less done, but we need to focus more on preventive action and some strategy we need to figure it out. Okay. So I believe that, you should go to patient bedside now as soon as possible and try to evaluate from your point of view and write it down or have the maximum point which can lead to such incident. I think this is one of the most important work you need to carry out today. And also try to figure it out. We'll definitely discuss in our office, but then try to also find out what can be the action plan based on the root cause analysis. So that should be our work today. So I believe that has to be a priority work at this moment for you. And also, as you know, Rosita, we always talk about ESCA, that is emotional and support for, coping anxiety. Look like today, Eva is little anxious, although she
Yes,
has
ma'am.
it. But I am thinking like, she must have taken care of the patient with epidural line after a long time and might be disturbed also. So look into this ESCA point of view also, because this is one of the things which always we take care of. Second thing, also ensure when you go to the ward whether they have recorded in quality track indicator tracking register as a quality indicator, because as you know, such incidents are occurring in healthcare organization. The percentage is around 6.5. Very recently, I was reviewing for some other reason, and studies say that 6.5% are having accidental delining, for which we have already, incorporated in our quality indicator, where whatever patients are coming to us with this kind of line, then we capture. And then if there is any accidental delining, we also record it. So look at that point also, Rosita. So I expect from that from you. Okay.
Yes, ma'am. I will go and definitely visit the area and we'll come up with the RCA and we'll give you the report tomorrow, ma'am.
Okay. So mommy, Eva, relax. Rosita, I hope she'll be able to do a fantastic job. And tomorrow I'll again discuss with Rosita, mommy. And then what we'll do, we'll also come up with all the discussion points, what is to be done. And we'll definitely come for the bigger forum where we can discuss, not only for surgical area, but even for other nurses also, because sometimes we do have a patient in other area apart from surgery area, like maybe pain cabin. So let's see. Okay, mommy?
Sure,
And
sure.
you have,
Yes,
yeah?
ma'am. Okay, ma'am.
Okay. So now you relax. Let us see what comes up tomorrow, right? Thank you
Okay.
once again.
Thank you
Yeah.
so much, ma'am.
Okay, thank you. Thank you so much.
Good morning, ma'am.
Hi, good morning, Rosita. How are you doing today?
I'm fine, ma'am. Good.
Good, good,
Ma'am,
good.
I have visited the area, so I came up with the report, ma'am.
Fantastic. Okay, fine. So, okay, fine. You must have written the report. That's okay. But prior to that, let us discuss. What did you find actually? What are the, kind of plan action we can have? So, can you tell me and what kind of tool you have used actually for the assessment of the problem?
Yeah, ma'am, as you have instructed yesterday, I used the fishbone diagram analysis technique to understand better about the incident and to come up with the RCA, and so that we can implement the corrective actions effectively. So there,
Very
ma'am,
nice.
I have focused on four main areas. One related to main, then method, material or the devices, and the environment aspect.
Very good. Very good. Yeah, please take one by one.
Ma'am, in the main aspect, what I find there is that the nurse-patient ratio in this area was found to be little bit on a higher side. That is, they were having one nurse getting 7 patients.
Okay, so let me note down also. Yeah, this is my job actually, nurse-patient ratio to be, in a better scenario. So, okay, nurse-patient ratio is one factor. Okay.
Then they were using the untrained staff for changing position of the patient.
Right.
Then staff nurse was having an experience of 4 years. She is competent, but what happened? Her training records shows that there are only few attendants when such training are conducted in the area.
Okay.
Then she was also having some personal issues that day, so maybe she is not able to concentrate fully on the patient care.
Right.
So these were the points I found out related to the main factor. So coming to the methods, what I find is that there was a gap in effective communications at different levels. For example, the handover from OT staff to the ward was ineffective. Then shift handover, though there is is-bar technique of we have that hands-off communication process, but that was not done effectively. Then
Okay.
at the same time, patient and family involvement and communication on the care was also found inadequate. So the patients and the family were not informed before doing the procedures. So they were not
Okay.
instructed what to do and what not to do. Then next, what I find is that assessment of the patient and catheter site was not done. So assuming that as because already the incident has occurred, we assume that maybe at the time the adhesive plaster may have not attached well to the patient's skin. So while they
Okay.
are changing the position, that particular catheter may have come out.
Okay.
Uh, SOPs is in place, ma'am. SOPs is there, but I found out that we need to update because there was pending from the last 3 months, so we need to update this SOP. Then
Okay.
alongside what I found is that, ma'am, there were also IV lines, peripheral IV lines, alongside this epidural line, but there were no proper identification and leveling was not done. We already have the color coded identification tag, but they were not using it. So maybe that they have underlooked this epidural line while changing the position. So as it is very thin line, very minute, so maybe that also one reason.
Okay.
Then in the environmental factor, ma'am, you have talked about device related also. So, but the
Right.
device is found good. There is no problem in that. I have talked to the respective concerned person. So device is no problem. Quality is good only. Then
Okay.
environmental factor, what happened is that usually such type of patients with the lines, so many lines, they used to be kept near to the nursing station. But what happened, unfortunately, for this patient, they have kept and assigned a bed which was little farther from the nursing counter. So these were the, ma'am, root cause that I found regarding yesterday's unfortunate incident.
Oh,
Um,
okay. So what would
ma'am,
be what would be the action plan you thought about it? Of course, we'll discuss, but did you figure it out, some action plan which
yes,
can,
ma'am.
yeah, please tell me.
So I have come up with some of the preventive action plans. Like number
Yes.
one point is that we need to definitely look into the nurse-patient ratio, though it
Okay.
will take time and it is not a immediate solution. So for such crisis, I think we need now to adopt this equity-based nursing. So I think
Okay.
staffing pattern. So I think it's the right time that we adopt this equity-based staffing pattern to solve such crisis at this point of time. Another
Mhm.
point is that we need to reinforce training and encourage the staff to for the training, and competency need to be looked again, because it is not one time that we are checking every 6 months or every yearly that we have this one. So I think we need to again focus on the competency the checklist of the staff. And on the training, I would like to put that we need to adopt some different module, because ordinarily we were having only lectures, classroom training. I think that it becomes very ineffective. So we need to adopt new model, new technique, like mode of training, like role play, then bedside, then also case presentation. So I hope this will be introduced. This, if we put this in the training, then I think that will give us a better learning for the staff, and they will
Yeah, yeah.
connect it better.
I think this is the need of hour, because we all agreed upon the classroom training does not help so much. So bedside training, case presentation, definitely it is going to help us. That's a very good point, Rosita. Yeah, any
Mm,
more?
yeah. Yes, ma'am. Yes, on the in communication aspect, most of the time our staff nurses face, they don't know what and how and what to communicate. So I think we need to include like this. Already we have this S-bar hands of communication. So we need to reinforce again such training like S-bar communication technique, edit script, teach back communication. We will be putting up this communication the training to the staff, so that they can learn better and communicate better with the patient and the attendants.
Right, right. Very
Then
nice.
Then we will also reinforce the use of color-coded identification and leveling of IV lines, that which is already
Right.
there. So we will be reinforcing again.
So
Then
look like
next
this
is
is a look like this is a little bit of deviation from the protocol. We have fantastic color coded sticker, for every line. I think somewhere it is not implemented. So we really need to look into, because we have invested so much of money on it, right? So we have to implement that, Rosita. So you'll highlight this point as well. Very nice. Anything
yes,
more?
ma'am. Yes, ma'am. Like we need to also look for the bed relocation and the location of the patients. Then
Okay.
we should not allow any untrained staff to take care, to assist the patient care area.
Mhm.
Then so what we have discussed so many things. So in order to check whether these process and protocols are in place, so ma'am, we have already scheduled the audits every 3 months in the high risk patient care area, so that these processes, what we talk about or what is already in place, are implemented effectively. Then
Okay.
we also need to have that KPI to be maintained and reported every means within 24 hours if any such problems, any incidents happen by the respective in charge. And ma'am, lastly, we will discuss this. We will discuss the trend of incidents area wise in the upcoming quality meeting. So, ma'am, these are the reports.
Oh, very good. So you have actually covered maximum point, as I understand, Rosita. Thank you so much for such detailed work. And of course, you have discussed with me, but put up in the report. As you rightly said, we need to definitely discuss very quickly in a quality forum. See, nursing department has got our quality committee, quality and safety committee. So put it in the agenda. And even though, we sit in the last day of every month, last Tuesday, I believe. So, but then we can have a quick meeting by this week itself. Rosita, I think you can plan for it. And let us
Yes, ma'am.
have the detailed discussion about what is the root cause and how we have gone ahead with the corrective action and what are the preventive measures, so that anywhere these kind of patients getting admitted, such incidents never happen. So learning from mistake is one of the most important thing at this moment. It's a need of our. Yeah, thank you so much. And I'll also inform Mommy and Miss Eva about it, so that they are present in the meeting. And most importantly, maximum number of staff from surgery ward has to be there in the meeting. That has to be ensured, Rosita. So that is to be done,
Yes,
right?
ma'am.
Okay, Rosita, just for discussion, I just want to tell you that, nurse-patient ratio, as you know, that you all know, we are a little bit of senior person, even though we talk about that nurse-patient ratio is a robust requirement, and everybody talk about it, and patient party to complain about it sometime, and so on. But then at the same time, we know about it. There's a problem globally. Attrition is high everywhere. Demand supply ratio is not matched. So those things are always there. But then how tactfully, how intelligently, how smartly our nurses are working to manage such important situation. Yeah, we can definitely delegate some of the menials of which nurses knowledge and skill is not so important. Yeah, but they can help us, so that it can be some of the non-nursing work, or some very simple work can be given to them, and nursing load will be reduced, right? So that can be done. So
Definitely.
we'll discuss this particular point also to come up with a proper ratio, but at the same time, how we can eliminate non-nursing job in the hospital. That should be one of the point I wanted to tell you. We will definitely discuss about it in our forum. And second thing is that please understand that all of us, I think we will definitely tell our nursing in charges that privileging is one thing. See, today, if at all I'm not trained, I'm not competent. I might be trained, but I'm not competent, right? So my training is first. Next is your competency assessment, whether the person is competent or not. And then once the person is competent, then person need to be actually tagged to the or mapped to the privileging. So privileging plays a very good on a very vital role, and all the record of privileging and competency assessment must be available in the ward, so that nursing in charge at any time, if they forget who is privileged for what, who is competent for what, so they can review. And accordingly, as you rightly said, the acuity-based nursing, assignment is a area now, and NABH and accreditation system also talk about it. So we'll look into this matter as well. And then, yes, patient and family education plays vital role here. Actually, it is not about after having the incident, but it is before that. Once the catheter is in place with the patient, then we need to educate the people surrounding to him. Like this particular case, Mr. John, his brother is there for 24/7, so we could have educated. So this is our learning lesson. So most importantly, I think we all have to, understand such a manner that there is, patients are in our safe hand. Everybody talked about safety practices, and patient safety is a key word now. And every dealing of our, work as a nurse need to think about that, how we can be safe, our hand can be safe for to take care of the patient. I think these things can be definitely discussed, and we need to vigorously. It is not one time, two time discussion. We need to have a periodic discussion as and when required. I believe these are the points to be looked into. And yes, sometimes we need to be empowered, because this is a empowerment again. Nurses don't have to really ask me or anyone to relocate the bed. In case if the patient need to be monitored very frequently, why not nurse will pull the bed near the nursing station so that it is easy for her, and the nursing inserts can also see in between, right? So those things can be empowered to the nurses. They might be little apprehensive because they may think that I need to take permission, but then we need to focus on empowerment of them, and then how they can be more, competent in taking care of it. So all these points are very crucial, and thank you so much for bringing it. And most importantly, there is no, I have not seen that somebody is trying to hide this incident. This is like something really to be admired and commendable. So Mommy, Eva, Rosita, all of you have done fantastic work. So let us wait for the meeting and come up with a discussion, have a fantastic environment so that our patients are in safe hands. Thank you.
Thank you, ma'am.
Okay, Rosita, you can leave now. Thank you so much. We'll come back again. Okay, this is about the role play of our team, but then we have a very, very important person with us at the beginning, as you said. We have a very prominent doctor with us. We are very, very fortunate and glad to have such senior consultant anesthesiologist with us. Her name is Dr. Karabi Patwari. She's in this practice for last 23 years. Can you imagine? You can think about her expertise. She's expert in managing postoperative anesthesia. Postoperative anesthesia. She also gives fantastic the anesthesia in OT, and she follow up all the cases in the floor. So with her guidance, nurses are learning in daily basis. So we brought her here to, request her actually to put her expertise in the subject. And we are very, very thankful, ma'am. And ma'am, you can be here in the screen. And Dr. Karabi is with me. We are very fortunate to have her here in our forum. Ma'am, thank you very much once again.
Thank you.
Yeah, and just over to you. I'm sure you'll be enlightening with a lot of good points for us, so that nurses will be doing much better. And it is a team approach. Over to you, ma'am.
Thank you. Thank you so much for your kind words. I had always said earlier, and I believe that personally, that doctors and nurses form a team for the betterment of the patient. Like it was mentioned earlier, zero harm to the patient is the goal of every medical professional. And nurses are in no way behind the doctors, because doctors cannot alone take care of the patient without the assistance of the nurses. Today, what the role play was really very good, and in detail it has looked into the matter of accidental delining of an epidural catheter. Today, in today's world, where every patient comes learning from the Google website about the entire treatment, of how a treatment should go about and how things are in the hospital, it is there is a big stress factor on the nurses, particularly who are in direct contact with the patient 24/7 in every shift. You know, you do not have the same kind of patient in the adjacent beds. Will have different kind of patients with different attendants having their own idea about treatment and things like that. So coming straight away of what the discussion is all about, the accidental delining. Now, about an episode, whatever happens, first, the thing that comes to mind is the knowledge about the particular thing that is happening. Namely here, the epidural catheter. Now, we as anesthetists, we use the epidural lines either for a one-shot anesthesia, or we keep a catheter to give post-operative analgesia to the patient. Normally, such patients, the epidural catheter is usually for 48 hours, and it is removed as per the directions. Sometimes what is followed as a protocol is the timing of the low molecular weight heparin that is injected to the patient. So the timing of the removal, the scheduled removal, it differs from patient to patient. So regarding the delining, accidental delining, the major thing that we learned, I'm trying to put it as simply as possible. How does it happen? It actually happens when we are shifting the patient. Shifting the patient from the trolley to the bed. We are repositioning the patient. We are changing the bedclothes of the patient. And thirdly, the most important part, we are simply ignorant about an epidural line. We do not know what is the epidural line at all. So these are the things that can cause the accidental removal. Like I saw in the role play, the sister was competent enough to handle an epidural, but she had a nursing aide who was probably ignorant of how to handle an epidural catheter or how to handle a patient with an epidural catheter. Probably that amount of assistance she did not have from her partner while shifting the patient's position, which caused the accidental delining. So when such a thing is there, when a repositioning is to be done to a patient, what is important that all the people who are handling the patient should be aware. If the sister in charge is handling the patient, she should be able to tell the other assistants exactly what she's supposed to do, which side is she's turning her patient. She should be telling the patient, I'm going to turn you to your right side or to your left side. She should tell her assistants or the aide, whoever is available there, that this is the side we are going to turn on the count of 3. Okay, so that communication part is most important. So what actually happens if it is delined, if a catheter is delined? The first thing, if it goes unnoticed, it can stay under the clothes. You have given a repositioning, but you're unaware that it has been accidentally removed. So what happens is patient will complain of pain. You will check the infuser bottle, the dressing is intact. You will check the infuser bottle, it is continuously dispensing the drug, but the patient is still complaining of pain. Okay, so that is one thing. Then what happens if it goes undetected for a long time? There can be an infection at the site, number one. Secondly, an ascending infection to the patient. Thirdly, there could be an extension in the hospital stay. And most importantly, all in all these things percolate down to causing immense patient discomfort. That will percolate down to attendant discomfort, regular complaints. The patient is feeling pain, which is distressing for all of us. Okay, so how do we detect an accidental removal? Accidental removal sometimes goes undetected. It is very important to understand that. If the whole dressing is out, then we are able to view the epidural catheter. It is fine. We know it is delined. But sometimes the entire thing is under the dressing, but yet the epidural catheter is delined. So how do we detect that? So whenever we are changing positions in such cases, we need to touch the dressing and feel, is it wet? Because under the durapore or micropore, whichever is used, or the dressing that is used, there are gauge pieces there which will be wet. So if you place your hand on the epidural catheter dressing at the site, there could be wetness, which should ring a bell that there is a leakage there. Secondly, if the bed sheets of the patients are wet, patient usually with epidural, they lie on their back out of fright, feeling that there could be pain or whatever. If the nurse changes the position, he's there for that time, then he will lie down on the back. There could be wetness on the bed sheets. So that is another thing that tells us that there could be a leakage. Thirdly, you will see the infuser bottle is dispensing the drug. The levels are decreasing in the bottle, but the patient is still complaining of pain. That is another aspect that we detect that there could be an accidental delining of the epidural catheter. Okay, these things, most of these comes with constant vigilance to know what to look for. Okay, so we need to be just a bit of alertness on our part as we go by the daily. This is not, it should not become a part of an extra duty or something, but a part, just as we are touching the patient, we make sure that we are turning at the same time, we are applying our hand on the dressing and checking, is it wet? Then we are safe to say that there is no accidental leakage or whatever, or the lines that is not delined, it is in place. Okay, so what do we do now? It has been delined, we detect that there is wetness, or like in the role play, the epidural catheter is visible, it has come out, the dressing is loose. So what do we do now? Number one, basic point, do not panic. That is the basic thing. It is not to panic, not to arouse everybody, and not to scare everybody around, particularly the patient and the patient's attendant. Because delining is not something that does not happen. It does happen. We need to first focus on that. It does happen. We would be happy if it does not happen, but yes, it does happen, even though it is in a very small percentage of things. So number one point would be, do not panic. We just need to reassure the patient. We need to reassure the patient, sir, while changing your side, such a thing has happened. So we need to reassure the patient, okay, you be back to your original position. Tell the attendant, I'm going to call somebody and inform, don't worry, this is all right. It is not going to harm him. Something has been removed here. We will talk to the doctor about this. Okay, reassurance is one more thing. Thirdly, inform an anesthetist as fast as possible. With the information to the treating doctor, an anesthetist should be informed immediately so that that person can come and look into, because what we dread as anesthetists is the removal of the catheter in toto, meaning entire tip of the catheter should also be out, whether it is during scheduled removal or accidental removal. So it is important for us. So an anesthetist needs to look at the patient immediately. Then the most important part comes is not to contaminate that area where the epidural was given. Immediately, the person who has detected can remove the wet dressing under sterile conditions and put a sterile dressing back to the patient. So though this accidental removal of epidural catheter is something that does not happen regularly, but does happen, what we need to take home from such episodes is that we need to keep our wits about us, not to panic, to inform the right people at the right time. And if it is detected, not to ignore. So to say that there is little wetness, it is okay, it is normal, let us keep it like that. You know why during my shift, such a thing should not happen? Should be bold enough to detect that. Yes, it is detected. Nobody really intentionally removes epidural catheters. That is why the word accidental. It is not intentional. It has just happened. Unfortunate, it happened during my duty hours, but yes, it does happen. So it is all right. If we have the correct group of people during such an episode, it is helpful for all of us that we can take a combined action against it. So it is important for us not to ignore, to keep the patient reassured, and to learn from our mistakes so that it does not happen. So thank you very much for having me to speak on this topic. I'm really thankful to all of you who have involved me. And I really do hope that with whatever little I've been able to share with you people today, we'll be able to give a much better care for our patients. Thank you so much. Thank you, everybody.
Thank you, ma'am. Thank you, Karami ma'am. It is a fantastic discussion. And I'm so happy that she has put up actually point by point. It's going to be really useful if at all we play again and then listen to her. So this is wonderful, ma'am. Thank you so much. So I think Ranju can take over.
Yeah, thank you so much, team. And thank you, Dr. Korobi, madam. for your informative and fruitful discussion. I'm sure that today's participant, the student, the nurses, and the faculties, they will be benefited from this discussion. Thank you once again, the team, for this wonderful presentation. Now I hand over to Madam Thangam. Over to you, ma'am.
Thank you so much, the Northeast chapter team. Thank you and congratulations for conducting such a wonderful discussion in a role play. And I'm very sure the participants who are sitting here, they would have gotten not only the epidural delining, many other things. Some of the things that I observed, I'm going to summarize here, is that the kindness with which that you are dealing the staff who was involved, that was commendable. And I really hope that in real life also, all of us learn that when a mistake happens, the person is a victim. There is, of course, there is a patient who is a victim. There is a second victim, the nurse, who is, probably, even if, as doctor said, we should not panic in front of the patient. She may not panic, but then internally, she is so much worried that what is going to happen to the patient, what is going to happen to her. Somebody is going to ask her to write the incident report. Somebody is going to ask that, don't you know that how you are supposed to take care, and blah, 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 blah. We will go on, pointing our finger. And that I really hope the participants have taken away from this role play, that both Momi and Pinaki and everyone were very kind in handling the situation. And I know when it really happens in life, it takes a lot of situational awareness to stay calm for the leaders. I've been in that place, because when something happens to a patient, our adrenaline rushes in. And suddenly, you really want to go and break your head somewhere. I mean, this is one of the incidents. There were incidents where I really wanted to go and hit my head against something to say why this had to happen. But then you have to tell yourself that, you are reacting because you had so many years of experience behind you. And those young nurses, they are experiencing their learning, but we need to learn from those mistakes. So I have before, let me just summarize what I heard from your discussion. There was, a comment about acuity-based staffing. Yes, that is very, very important to know that which patient needs what kind of patient ratio. Talked about training, competency, privileging for special procedures, ensuring that nurses who look after such important lines are trained and privileged. That's a great focus to have for all the leaders, not just simply putting somebody in a classroom is privileging. No, you have to actually go to the bedside and ensure that this person is competent enough to look after that kind of, patient. So privileging, that was important. Where the patient is kept, keeping this as one of the KPI, delining of all kinds of tubes and lines are important. Then also mentioned about auditing at every 3 months. All good ideas. I would just like to add, when you're doing the 3 months audit, ensure that it is a prevalence audit. That means it should be unannounced audit, not an announced audit. It should happen random, just like that, so that whether nurses are practicing safely when these lines are around. So, and there's a lot of focus on communication. I really liked, starting with all the nurses who are here, including doctor. She mentioned about, communication between the caregivers, between caregivers and the patient. So I have a question to Dr. I'm sorry, I'm getting a
Dr. Karabi.
Dr. Karabi. Karabi, is that, in my experience, one of the things for delining, especially when the lines are at the back, is that the plaster that we put, it tends to roll. It tends to open and it tends to roll. Then the sticky part is actually sticking to the dress or to the bed sheet. So when you turn the patient, it comes away with the sheet, with the adhesive, and with the line. So this is something that had happened. So what we did was that we had to actually demonstrate on something else, not on the patient. We actually did it on a simple, kind of a stick, on just a ruler. We showed how this will roll up. And then when you turn, you actually pull off everything. So we train the nurses and also the assistants to show that this is what happens when you don't pay attention. I'm an intensive care nurse, so I have handled patients with so many lines. So one of the basic principle that we used to train our nurses and everybody else is that one very good thing you talked about, 1, 2, 3 turn. It's very important. We should not feel shy to tell these things loudly. So the nurse in charge is, I'm the nurse in charge taking care of the patient. So I will say, okay, let's turn the patient. We have a ventilator, we have an epidural line, we have IV lines. Let's see that all these lines are in place. Then we will say, okay, as we turn, let's look at the epidural dressing. Is it intact? Then to do all the things that ma'am told, is it wet? Is it in place? And I also used to have one of the safe practices I developed and all our nurses used to do is to actually put a small plaster at the exit point of any lines, and put one roll of plaster nicely stuck. And I used to use a pen and put an arrow to say that this is where the line is going inside. So if that sign moves anywhere, I know this line has moved. One of the other things that can actually go wrong with such thin, long lines is, as ma'am told, it can come out within the dressing. And everything else may look intact and say, oh, then it is the wetness or the patient complaining of pain. So I would emphasize that, every time we must know our own patient. When a patient says, I'm still having pain, don't say, shoo, you are getting medicine. We are giving you medicine, sir. Thoda bahut to dard to hoga hi. Don't respond like that. Try to think that why is my patient complaining of pain despite getting epidural analgesia? This is very important. Sometimes maybe the analgesia is blocked, it's not flowing, but this is very dangerous. The line is in place, it is flowing into some other compartment. It is not going into the epidural space. So the patient continues. So very important to know our patient. Nowadays, what happens with our nurses is that they tend to be a little bit robotic and automatic. I just have to do 10 things for this patient. I just do these things. And then that's it. So I really request all the young nurses, learn to know your patient. A patient is not equal to B. One TKR is not equal to the next TKR, though they may have a similar line of treatment and surgery, but every single patient is different. Every single patient looks and feels different ways. So knowing your patient is very, very important. And doctor emphasized one more thing. In front of the patient, do not panic. In front of the patient, in charges, do not start asking questions. Don't ask the assigned nurse, what happened? You did not see when you turned the patient, why the line is coming out? You did not, oh, sorry, sir, the line came out. Why did you do this? You're already telling the patient that nothing is right in your department. So it is very important, once again, to all the leaders, stay calm when something happens. You can be angry, you can be irritated. It is very normal. But tell yourself, I have a situation. Now I need to handle it. I really like the way Momi was responding very calmly and quietly. And I was praying to myself, I really hope that everybody is learning, that everybody will be able to keep that calm in real life incident also. This is very important. And I really liked one more thing that Rojita mentioned, that, Eva was having some personal concerns, on that particular day. Now that is very important. One more very important leadership lesson for all in charges and all leaders sitting here, know your staff. I told one thing, all nurses should know your patient. Now I tell all the leaders, know your staff. When they are having tough time, understand, be there. That is why we talk about, we huddle, briefing and debriefing. In army, when you start a mission, there is a briefing where the leader says, okay, this is our mission, this is our target, and we are going to do this. This is the strategy we are going to adopt today. So I tell, when you start a shift, let's say Momi is in charge. So she's working with 2-3 more staff. So after taking over, mommy will do a briefing and say, okay, team, come, 3 minutes, quick briefing. So you will be able to tell, not Rojita, Eva, to say, Eva, you have a patient with epidural line. So please make sure when you turn the patient, take extra care. And if needed, you need to call me. And nursing assistant is new today, so don't call him. We will use, but we will try to train. So you call me. If you are busy, you call me. We don't want to have any situation unwanted. So that is called briefing. Briefing for the team by that particular, many people get confused with shift handover and briefing. We should not do that. Briefing is just before when you start your work. It's like in the OT, when just before starting, doctor might be briefing her technician and everyone. She will not take a class outside for 5 technicians for that surgery. It doesn't work. So it is better to talk with your own team, brief, and then very important, when you finish the shift, to do a debriefing, asking everyone, hello guys, we are almost there, finishing our shift. How did it go? How did it go, Eva? Were you comfortable? You turned your patient. Great job. We all helped each other. Eva might say, I found it difficult. I had 7 patients. So Momi will say, I can understand. I'm really sorry. I hope that you got the help that you wanted during the shift. So during briefing, you're able to assess your acuity as well. If the staffing is safe for everyone, do I need to do any shifting? Not just stick by the assignment put by the previous shift. So there is so many practical things that we need to bring in. So I just thought I will add a little bit of more value from my 40 years experience, 16 years in critical care, 12 years in administration. And from then on, now on, I am education training, meeting so many people. And I'm so glad that the chapter headed by Dr. Ranju, Pinaki, Momin, Rojita, and Eva, and of course, Dr. Kamadi, that, thank you so much. And you are our pioneer for starting our multidisciplinary discussion. So we'll always remember that. So I do know that you have created a slide of 14 slides. I have seen that. So I have a request, ma'am, that in case you can do a video recording of the session with those 14 slides, and you hand over the video to us, we will ensure that we get it uploaded on our YouTube channel, because I'm sure that you prepared this for this day. And since the format is role play, so we said, let's not use any slides. That was the request. So I don't want that effort to go waste. And I'm very sure once it gets onto the website, our website, YouTube, many more can watch this and learn, because it is very important that if we fail to learn from others' mistake, we are actually waiting to make many mistakes. I used to tell my nurses, I had 400 nurses, one nurse made a mistake. If I don't talk about it, I am giving 399 more nurses an opportunity to make the same mistake. So that's why it is very important to learn from the mistake. We need to be kind. The staff nurses should not feel that why I'm being asked, explain, like Pinaki asked, please explain what happened. Maybe they may have to explain 3 times. Maybe in a RCA meeting, they have to explain, maybe to a quality. We should not feel that it is a punishment. It is being done so that we can learn from it, not to penalize the staff, but rather to learn and understand that what could have gone wrong, what we need to take care. There are many, structural changes may be required, maybe process changes is required, maybe training is probably, if you look at the quality improvement hierarchy, training actually is at the bottom. Training is not the solution to prevent harm. It is one of the strategy, but there are many other things that we need to look into, and human factors play a major role. So I was trying to summarize all that you have discussed. I hope I added value. And before we wrap up, I'm going to open the audience to ask any questions or any comments. If you have, please go ahead and, ask any questions, any comments, anyone. I saw Dr. Unmuna in between for a second. And if Dr. Unmuna is still there, I would ask her to please come on the screen and, please give your...
Okay, ma'am. On the very onset, I congratulate each team player. And of course, Dr. Korobi, such informative and being here and giving your valuable time. Just when the topic came, actually, as I also was occupied and Ronju also silently thinking then how this thing will go, and yes, it is very important just to hear like 1 person, 2 person talking. It is not so interesting, but I really wondered throughout. I was there just looking at passport size photo. I was going through the hospital, going to the nursing office, and also all the quality control protocol, etc. really in front of my eyes, I can feel. And behind that is only, again, I'll say, Ma'am Thangam. So I just want to thank you, Dr. Korobi. I want to thank Pinaki Madam, whom I say Baidio, close to my heart, Dr. Momi Neu, also Rajita, who was with me for almost 10 years. Just last month, she left us to Apollo. And Eva, she is there in our hospital only. And Ronju, this is the first job. I believe that it is excellent job and what we have done. And the initiative, and ma'am, through this role play, I never thought, whole connected map we could make out, root cause, the relation, social, how we have to talk, how we have to communicate, how we need to be conscious, and there's so many other things came out. Even book is not enough, ma'am. You are the real ideator, and looking forward to have many more that error to learn. We don't want to have error, but errors what happen that we can learn if we can present over here. Thank you, ma'am. And I thank all the participants for being here continuously and looking forward to see you in our next Empower Hour also. Thank you, ma'am. Thank you, Ranju.
Thank you. Thank you, Dr. Unmuna. And yes, we will be back in July. And July, to catch up with what we missed in May, we would hopefully have 2 Empower Hours. And for that, just give me a moment. I'll share my presentation once again. And this is the event that we discussed, okay? So thank you everyone for committing to patient safety, and we welcome you back for the next sessions. But before that, one call out to all our participants here. Please join us and make us, more powerful with more voice, more ideas, so that future of nursing and nurses become brighter in our country. All you have to do is to visit our website, www.anei.in, to join us. And in the next month, we are going to discuss 2 events: wrong site procedure and a medication error, will be hosted by Maharashtra and Kerala chapter. So thank you everyone for being here and spending time, and we are right on time, 12:18. 12:20 is our deadline, so we have discussed a lot, and as Dr. Unmuna said, all aspects and so many things we could showcase. So thank you, team, for being here and giving such an empowered hour for all of us. Thank you so much, and I'm going to now stop the recording and say bye. And don't go away. After I stop recording, we will open in case someone wants to talk, because some people are shy of the recording that's happening. So thank you once again, and very special Dr. Korobi, please. Thank you so much for being here, and thank you everyone else, and more members and more powers to Association of Nurse Executives India. And we will see you next month.
Thank you.